Hello everyone. So let's start our discussion on the disease of gastrointestinal system in pediatrics, university question answer discussion. So different questions which are asked in our university exam about this gastrointestinal system disorders. Some of the questions as short as is asked, write the composition of the oral rehydration solution, enumerate the management of a 2-year-old child with acute diarrhea disease with no dehydration. So acute diarrhea disease is one of the most common questions which are usually asked in our university exam. And their management, that is the management of the acute diarrhea disease with the no dehydration, some dehydration, severe dehydration. These are all the short essays. And also, another question is that a 2-year-old female child weighing 8.2 kilograms brought to the health center with the complaints of vomiting and diarrhea. How will you approach the child and provide the management in the details? So, we have to assess the child for the dehydration, and following that, we have to manage accordingly. Then another question is that describe pathogenesis, the clinical features and management of the acute watery diarrhea in the infancy. The next question is as short answers as oral rehydration therapy, then rehydration solution for the malnutrition, then about the management of severe dehydration in the 1-year-old child being 10 kilogram, then then about the management of different kind of dehydration. So these are the basic or usually asked question patterns in our university exam about the disease of gastrointestinal system, about the only acute diarrhea disease only. Then we have the gastroesophageal reflux disease, about the then about the gas, then the cause of the splenomegaly in the children, then about the uh, obstetric jaundice, then the portosystemic caudal hypertension. Then these are the important questions which are usually asked from our GIT chapter. Also about the Wilson disease or the then Wilson disease also, there will be questions are there. So these are the major questions regarding the gastrointestinal disease. So uh, we have to learn one by one that. Okay, so first of all, we are going to start with the acute diarrhea diseases. So one of the question is that describe the WHO plans for the management of the acute diarrhea in the children. In the later, we are going to study that. So then the definition of the acute diarrhea disease, which include the passage of 3 or more loose stools in 24-hour period, loose stools that takes the shape of the container, recent change in consistency or character of the stool. So as a definition, it is the recent change in the consistency as well as the frequency of the stool is called as the acute diarrhea diseases. If there is an increase in the frequency if there is an increase in the or a watery consistency of the stool, it is called as the acute diarrhea diseases. Then the acute, which means it lasts less than 7 days, up to 40 days without visible blood, is also called as the acute water diarrhea. If it is greater than 40 days, it is called as chronic water diarrhea. And the acute water diarrhea, which are prone to dehydration. So we have to treat accordingly immediately. Then the dysentery, which means visible blood and mucus. So if a question is asked regarding the acute diarrhea diseases, any essay question, we have to first write regarding the definition. That is, it is the increase in the frequency as well as the change in the consistency of the stool is called as the diarrhea disease. And if it is less than 7 days up to 40 days, it is known as acute diarrhea disease or acute water diarrhea. And it is more prone for the dehydration. These all points which have to be written in our definition of the acute diarrhea diseases. Then something about the epidemiology, that is 1.5 million children die of diarrhea annually because of dehydration related complications, and 8 out of 10 deaths in first 2 years of life is due to the acute diarrhea diseases, and 20% of hospitalized pediatric cases in India is also due to acute diarrhea diseases. Then, if the question in the question asked about the risk factors, these are the risk factors like infections, poverty, non-breastfed babies, severe acute malnutrition, measles, and human immunodeficiency virus. These are the risk factors for the development of the acute diarrhea diseases like infections, poverty, non-breastfed babies, severe acute malnutrition, measles, and human immunodeficiency virus. Then about the etiology of the acute diarrhea diseases, the acute watery diarrhea The most common, common in the infants is the rotavirus infection, and the also some bacteria also leading to acute water diarrhea like Escherichia coli. In that there will be enterotoxigenic and enteropathogenic E. coli and Shigella and Campylobacter jejuni, which are also important causative organism for the acute water diarrhea. But rotavirus is the very common in the infants, and also enteroviruses and also Vibrio cholerae, that is the characteristic stool appearance like rice or watery stool. These are the etiological factor for the acute water diarrhea. And the dysentery, that is blood in the stool, which is caused by the Shigella dysentery and this the Campylobacter jejuni, Salmonella, Entamoeba histolytica. So rotavirus diarrhea, which is common between the 9 months and 12 months of age, it is common in the winter in India. A reversible patchy villus atrophy with the loss of breast border enzyme is the cause for the rotavirus diarrhea. And important clinical feature is vomiting preceding the onset of the diarrhea. Then other etiology factors, travel is diarrhea and also drug-induced diarrhea, which contributes to acute watery diarrhea. Then another question, a sub-question in our essays are as clinical features of acute diarrhea. The most important clinical consequence is the dehydration, the treatment plan which depends upon the severity of the dehydration. So this is the table which showing assessment of, that is WHO assessment of dehydration, which is usually asked as a sub-question in every essay regarding the acute diarrhea diseases. Um, so the WHO, which divides these dehydration status into different categories, that is the acute diarrhea disease with the no dehydration, then acute dehydration with some dehydration, acute dehydration with the severe dehydration. So this is the assessment of dehydration of the patient with diarrhea according to WHO. First, we have to look for the condition of the child. That is whether the child is well alert or restless or irritable or lethargic, unconscious or floppy. So if the condition of the child is well alert and the eyes are normal and the tears, there will be normally present tears is there, then mouth and tongue is moist and the thirst, the child drinks normally and not very thirsty. And when we assess the skin target, if we pinch the skin, it goes back quickly, and the decision is, or it is categorized as the acute diarrhea disease with the no dehydration. That is, the child is classified with these features as the acute diarrhea disease with the no dehydration and plan accordingly by the WHO. And the next category is that the condition of the child is restless or irritable and the eyes are sunken, that is a feature of dehydration, or the tears which are absent because of the dryness, or the mouth and tongue is dry, or the thirst is, that is child is very thirsty and drinks eagerly when we give water. And then we assess the skin turgor, it is goes back quickly, that is not goes back quickly, it is goes back slowly, that is then the decision, or the child is classified as the some dehydration. That is, if these more than or equal to two signs are present, any of these two signs are present, it is classified as the acute diarrhea disease with some dehydration and managed according to the WHO managed for the some dehydration. Then another category is that if the condition of the child is lethargic or unconscious or the floppy, and eyes which is very sunken and dry, and the tears which are absent, and the mouth and tongue is very dry, and thirst is that drinks poorly and or is not able to drink. In the some dehydration, child is very eagerly to drink, but in the severe dehydration, the child drinks poorly or is not able to drink properly. And while assessing the skin turgor, it is the when we try to pinch the skin, it is go back very slowly, that it's more than 2 seconds. And if any of these two signs or more than or equal to two signs are present, it is classified as this child as the acute diarrhea disease with a severe dehydration, managed accordingly that. So that is the one of the WHO assessment for the patient with the diarrhea, and with this categorization, we have to manage accordingly. Then assessment of fluid loss. If there is no dehydration according to these features, it is less than 50 ml per kilogram of the fluid loss is there. If there is some dehydration, 50 to 100 ml per kilogram fluid loss is there. And severe dehydration, greater than 100 ml per kilogram fluid loss is there. In addition, for the dehydration examination, we have to examine for the malnutrition, that is anthropometry for the weight and height, examination of the wasting, edema and vitamin deficiency we have to look for. And also we have to look for any systemic infection, that is presence of cough, high grade fever, fast breathing of the chest, improving or sensitive of the pneumonia, and also high grade fever with the splenomegaly, sensitive of the malaria. We have to look for any systemic infection. And also we have to look for the fungal infections like oral thrush or the perianal lesions. Then we have to go for laboratory investigations. There is stool microscopy. We have to look for the darting motion test in the case of Vibrio cholerae and trophozoites in the stool for the giardiasis. And also we have to go for stool culture to detect the Shigella dysentery. And we have to go for hemogram, blood gas estimation, serum electrolytes, and renal function test indicated if the child is associated with the pallor, labored breathing, altered sensorium, seizure, paralytic ileus, and oliguria. Um, which suggest acid-base imbalance, dyselectrolemia, and renal failure. So these are the assessment or the investigations we are, or examination part we are doing when a patient is coming with, child is coming with acute water diarrhea. First, we have to look for the signs of dehydration and categorized according to that. Then we have to uh, look for the water loss according to the categorization, or fluid loss according to categorization. Then we have to assess for the stool and stool microscopy, stool culture, and also look for any systemic infections and malnutrition, fungal infections. And also we have to go for hemogram, blood gas estimations, and electrolytes and RFT. So these are the investigations by when a child is coming with acute diarrhea disease. Then another sub question of the essay is the principle of the management of the that is what is the management of the acute diarrhea disease when the patient is present with the vomiting and diarrhea. So the principles of management. First, we have to written about the principles of management in management of the acute water diarrhea. There is principles of management which include, first is the rehydration and maintaining hydration. That is rehydration, which means water or the fluid is lost, we have to rehydrate for that, and also maintaining the hydration. Then ensuring the adequate feeding, we do not have to stop the feeding. We ensure the adequate feeding and oral supplementation of zinc, and also early recognition of danger signs and treatment of the complications. So these are the principles of management. First is rehydration and maintaining of hydration, then ensuring the adequate feeding, then oral supplementation of the zinc, and early recognition of danger signs and treatment of the complication. These are the principles of management of the uh, acute diarrhea disease. Then a short note is based on the oral rehydration therapy. That is glucose dependent sodium and water absorption is the principle behind the replacing glucose and sodium in the 1:1 molar ratio in the WHO oral rehydration solution. That is along with the glucose, the sodium and water is also absorbed. That is the principle behind this oral rehydration therapy. Because the glucose dependent sodium pump which remains unaffected in diarrhea, so we have to give the oral rehydration solution along with this glucose, the sodium and water is also absorbed. So osmolarity of the replacement fluid should not exceed that of the blood. That is, blood's osmolarity is 290 millimole per liter. So the osmolarity of the replacement fluid is less than that of the 290 millimole per liter. So our low osmolarity ORS. So we have to prepare the low osmolarity ORS, which causes the reduction in the stool output, decrease the vomiting, decreased use of unscheduled IV fluids, and without increased risk of the hyponatremia. So the blood's osmolarity is 290 millimole per liter. So our low osmolarity ORS, which contains 245 millimole per liter of the osmolarity, that is called as the low osmolarity WHO ORS, which is currently used. Then about the composition of the WHO recommended ORS, this is a table which showing the constituents of WHO ORS, that is which constituent as sodium chloride 2.6 gram per liter, and the anhydrous glucose 13.5 gram liter, and the potassium chloride is 1.5 gram, and trisodium citrate is 2.9 gram, and the total osmolarity is about 245. So this is the composition of WHO recommended ORS. Then about the super ORS, it is a cereal or rice-based ORS. It is fortified with glycine and alanine. They decrease purge rate as well as slow release of glucose from the starch, effective in patient with the cholera. So super ORS is effective in the patient with cholera. It is a cereal or rice-based ORS. Then we have the super ORS in addition of the zinc to super ORS. That is, the above is the super ORS. In addition, we have to add the zinc to the super ORS. Improved absorption of water electrolytes by the intestine, faster regeneration of gut epithelium, reduces the severity and prevent the recurrent episodes of diarrhea. Then we have the Resomal. That is, Resomal is a rehydration solution for the severely malnourished children who have potassium deficiency but have the high levels of potassium. So in the Resomal, we have to supplement high levels of potassium and low levels of the sodium. So Resomal, which contains high levels of potassium and low levels of the sodium. Usually, in from our home, we have to prepare the Resomal by adding 1 liter of sachet packet of the rehydration solution to 2 liters of the water. Usually, we prepare this oral rehydration solution of the WHO by the adding the 1 liter sachet to the 1 liter of the boiled and cooled water. But to prepare the Resomal, we have to add this 1 liter sachet of ORS packet to the 2 liter of water and add 4 gram potassium and 50 gram sucrose. We have to prepare the Resomal by from the ORS packet by this method. So these are about the WHO or oral rehydration therapy. It is also asked as a short question or short note. So we have to explain everything, that is mechanism or principle behind the ORS, then what are the causes of the, that is what results when we give the ORS to this patient, and what is the composition of the recommended ORS, then about the super ORS, super ORS and Resomal. Also, there will be a short note asked about the Resomal. So we have to write about the difference between the Resomal and ORS, that is the Resomal, which have the increased potassium content and decreased sodium content. That's all about the short notes. Then about the home available foods, that is, instead of ORS, we can also give the home available foods to the children. That is, acceptable home available fluids are the fluids that contain salts. Preferred are the salted drinks, that is salted rice, water, and yogurt, vegetable or chicken soup with the salt. And fluids that do not contain salt is acceptable. That is acceptable. That is plain water, water in which cereal has been cooked, like unsalted rice water, unsalted soup, yogurt drinks without salt, which can also be green coconut water, which can also be used. And unsuitable home available fluids are the commercial fruit juices, commercial carbonated beverages, sweetened tea, which are the unsuitable for the home available fluids. So these are the alternative for the oral rehydration solution. That is a home acceptable home available fluids to prevent to rehydrate the child. Then our major topic is the treatment plans for the acute watery diarrhea. That is, treatment plan is depend upon the categorization of WHO or dehydration assessment categorization. That is, treatment plan A is for the treatment of no dehydration, and the treatment plan B is for the treatment of some dehydration, and the treatment plan C is for the treatment of severe dehydration. And this no dehydration, some dehydration, severe dehydration is based on this categorization. I have already told that in that table, that is, we have categories based on the dehydration features. So these are the categorization: non dehydration, some dehydration, severe dehydration. Then treatment plan A is for the no dehydration. That is, if a question is asked as if a child is present with acute water diarrhea and the child is investigated to have, or child is assessed to have no dehydration, that is acute water diarrhea with no dehydration, what is the treatment plan? The treatment plan, so we have to write with the treatment plan A is used for the no dehydration. Such children which must be treated at home after explanation of feeding and the danger signs to the mother or caregiver. And the danger signs are the continuing diarrhea beyond 3 days, increased volume or frequency of stools, repeated vomiting, increase in thirst, decreased urine output, refusal to feed, and fever and bloodstream stool. These are danger signs which have to be advised to the mother. If there is any of these danger signs present, we have to take the child to the hospital. So, such children, so non-dehydration children should be must treated at home, not hospitalization is required. After explanation of feeding and the danger signs to the mother or caregiver, the child should be managed at home. And in that children, we have to give the ORS. Um, if the age is less than 24 months, we have to give 50 to 100 ml of the ORS. And if the age of the child is at 2 to 10 years of age, we have to 100 to 200 ml. And if the greater than 10 years of age, we have to add ORS liberally. That is, when while giving the ORS, give a teaspoonful every 1 to 2 minutes for a child under 2 years of age, and give frequent sips from a cup for an older child. If the child vomits, wait for 10 minutes, then give solution more slowly. If diarrhea continues after the ORS packets are used up, tell the mother to give other fluids or return for the more ORS. So that's all about the treatment plan A. That is, the child should be managed to the child should be managed at the home after explaining the feeding and the danger signs to the mother or caregiver. This is the ORS ORS level. After or so the other culturally appropriate fluids after each stool. This is the amount according to age. So that is the regarding the plan A. Then treatment plan B is for the child with the acute water diarrhea with the some dehydration. All cases with obvious signs of dehydration need to be treated in a health center or hospital. Oral fluid therapy which must be commenced promptly and continued during transport. The fluid requirement is calculated under the following three headings. That is provision of the, we have to supplement the fluid requirements. So first requirement is for a provision of the normal daily fluid requirement. And the second is for the deficit replacement or the rehydration therapy. And third is for the maintenance of the fluid therapy to replace the ongoing losses. So these are the three headings for the fluid requirement in this Plan B treatment. So first is the provision of normal daily fluid requirements. Up to 10, it is by the Holiday Saga formula. This up to 10 kilogram, we have to give 100 ml per kilogram, and 10 to 20 kilogram, we have to add to this, that is 1000 ml per kilogram, we have to add the 50 ml per kilogram for each increase of the weight above 10 kilogram. Then we have to, then if the weight is greater than 20 kilogram, we have to add that is 1500 ml plus 20 ml per kilogram for each weight above 20 kilogram. So that is the Holiday Saga formula. So provisional normal daily fluid requirement is calculated by the Holiday Saga formula. The next, the fluid requirement is for the deficit replacement or the rehydration therapy. The rehydration to correct the existing water or the electrolyte deficit, it is calculated as the 75. That is, it is to replace the water loss. So it is calculated as a 75 ml per kilogram of ORS to be given over 4 hours. That is 75 ml per kilogram of ORS to be given over 4 hours. It cannot be taken orally. Then if the child cannot be taken orally, then nasogastric tube can be used. If the child's weight cannot be taken, then only age which may be used. So this is the guidelines for treating patients with some dehydration according to age. Then we have the third fluid requirement is for the maintenance of the fluid therapy to replace the ongoing losses. That is, it is only begin when the signs of dehydration disappears, so usually within 4 hours, and ORS should be administered in the volumes equal to diarrheal losses equal to a maximum of the 10 ml per kilogram per stool. And the breastfeeding and semi-solid foods are continued after replacement of the deficit, and the plain water can be offered in between. So that is all regarding the plan B. That is, these children have to be hospitalized or outpatient treatment, and then we have to oral fluid therapy must be commenced promptly and continued during transport. Then at the hospital, we have to fluid requirements based on three headings. That is provision of normal daily fluid requirements, then replacement replacement or rehydration therapy, then the therapy to replace the ongoing losses. According to these three headings, we have to give the fluid requirements. Then uh, then treatment plan C is the children with the severe dehydration. We have to go for treatment plan C. That is, intravenous fluid should be started immediately using ringer lactate with the 5% dextrose. So in the severe dehydration, we have to give the intravenous fluid should be started immediately using ringer lactate with the 5% dextrose. A total of the 100 ml per kilogram of the fluid is given over 6 hours in the children less than 12 months and over 3 hours in children greater than 12 months. That is, if the child is less than 12 months of age, the 100 ml per kilogram is divided into 30 ml per kilogram and 70 ml per kilogram in every child. And the total 100 ml per kilogram in the less than 12 months is given over 6 hours, and the one of in the 1 hour we have to give 30 ml per kilogram. In the first 5 hour, in the late next 5 hour, we have to give the 70 ml per kilogram. And if the child is greater than 12 months, we have to give this 30 ml per kilogram of the total 100 ml in 30 minutes, and the 70 ml per kilogram in the 2.5 hours. That is total 3 hours. We have to give this ringer lactate and 5% dextrose in greater than 12 months of age. And also, if oral solution should be started immediately if the child can take an orally. If IV fluids cannot be given, nasogastric feeding is given at 20 ml per kilogram. If the it is the IV fluids is the treatment choice for the severe dehydration, and if the IV fluids which cannot be given because of some reasons, nasogastric feeding is given at 20 ml per kilogram per hour for the 6 hour. The child should be reassessed every 1 to 2 hours. If there is repeated vomiting or the abdominal distension is there, the oral or the nasogastric fluids are given more slowly. If there is no improvement in the hydration after 3 hours, IV fluid should be started immediately in the case of nasogastric administration. And the child should be reassessed every 50 to 30 minutes for the pulse and hydration status after first bolus of the 100 ml per kilogram of the IV fluid. So we have to check for pulse and hydration status after first bolus of 100 ml per kilogram of the IV fluids. Then management following the first bolus of IV as follows. That is, if there is persistence of severe dehydration, IV infusion is repeated. But if the hydration is improved, but some dehydration is present, IV fluids are discontinued. ORS is administered over 4 according to Plan B. That is, here the severe dehydration is relieved and there is some dehydration is there. So some dehydration is treated according to Plan B. And if there is no dehydration, it is IV fluids are discontinued and treatment plan A is followed. That is, for the no dehydration, treatment plan A is followed. And child should be observed for at least 6 hours before discharge to confirm that the mother is able to maintain child's hydration by the ORS. So that's all regarding the management of the different categorization of the diarrhea disease. That is for the treatment plan. A is for the no dehydration, B is for the some dehydration, C is for the severe dehydration. Then, in the case of nutritional management of the diarrhea, children with a severe malnutrition are at an increased risk of developing both acute diarrhea and its complications like severe systemic infection, dehydration, heart failure, and vitamin and mineral deficiencies. Feeding should not be restricted in such patients. The feeding in diarrhea decreases the stool volume by facilitating sodium and water absorption, along with the nutrients, facilitates early gut epithelial recovery and prevents malnutrition. Once the child status starts improving, a higher than recommended intake is given to facilitate complete catch-up growth. So, the recommendations on dietary management of acute diarrhea, that is, we have to give a diet along with this treatment for the dehydration. That is, breastfeeding continued in the breastfed infants. Small, frequent, energy-dense foods every 2 to 3 hours. Staple food enriched with oil, the sugar should be given. Undiluted milk, avoid high fiber diet. Routine lactose-free feeding is not required. Don't use cold drinks, fruit juices, or the glucose solutions, and drink during recovery. An intake of at least 125% of the recommended dietary allowance of the nutrients is required. Then along with the we have to supplement the or along with the ORS, we have to supplement the zinc supplements. Intestinal zinc losses during diarrhea, which aggravates pre-existing zinc deficiency. It decreases severity, duration, and reduces the risk of persistent diarrhea. It is supplemented as zinc sulfate, zinc acetate, or gluconate formulations. In the children greater than 6 months, we have to give the 20 milligram per day for the 14 days. Up to 6 months, we have to give 10 milligram per day for the 14 days. So the dose is important. It is asked as a 1 mark question. Then symptomatic treatment is also used for the diarrhea diseases. That is the antiemetics which are used for only in the vomiting. Then a single dose of ondansetron 0.15 milligram per kilogram dose should be given. And abdominal distension which doesn't require any specific treatment. Hypokalemia along with the paralytic ileus, we have to give the IV fluids and nasogastric aspiration. Correction of the hypokalemia and no oral feeding is required. That is, potassium chloride should be administered. That is, hypokalemia is due to loss of potassium chloride. That is, abdominal distension is due to the hypokalemia. That is because of the loss of potassium chloride. So we have to administer potassium chloride should be administered intravenously with the parenteral fluids provided the child is passing urine. Then also associated compulsions which have to be treated, and drug therapy, usually antibiotics is not indicated in the diarrhea disease. If there is any bacillus dysentery, we have to give the antibiotics. Then anti-motility agents and the anti-secretory agents like rasicadotol, which are nowadays which are usually used. But major also probiotics are also used like lactobacillus. So mainly the fluid is the mainstay of treatment of the acute diarrhea diseases. That is fluid replacement. Then how to prevent diarrhea and malnutrition? Three main measures are proper nutrition, adequate sanitation, and vaccination, which are the three main headings for the prevention of diarrhea and malnutrition. So that is all regarding the acute diarrhea disease. Thank you.